I'm Sarah Allen. I'm an associate professor of health policy at the Institute of Health Policy Management and Evaluation in the Dalla Lana School of Public Health. I'm also one of the co-leads of the resilience theme of the Institute for Pandemics, along with my colleague Brian Bagri, Fahad Razak, who was here earlier. And we've kind of conceived of this panel because we, for our own sort of selfishness, wanted to learn from some of the leading thinkers and scholars in the area of resilience, with a focus on some of the themes that have been really resonating throughout the day around partnerships, community engagement, public communications and science communication. And so you'll see some of these themes coming up in today's panel. And it's my great pleasure to introduce our keynote speaker of our panel, Dr. Magank Shale, who will be kicking off the panel. And he's extremely well placed to tackle these issues and to kick off the discussion. He's an accomplished medical researcher, writer, and strategic content creator with a passion for global public health. And he earned his medical doctorate with honors from Xavier University School of Medicine. He's had a lot of experience in medical fields, including neurosurgery, addiction and mental health, strategic health communications, and medical content development. Currently, he serves as strategic communications consultant at the World Health Organization in the Department of Communications headquartered in Geneva. His research interests focus on exploring data-driven strategies to develop effective social media communication campaigns, establish an expert online presence, and promote messages to target audiences. Through collaboration with WHO teams, he promotes messages and creates positive social impact. So we're really thrilled that he was willing to come and speak with us today. And I'm going to turn it over to Dr. Shale to give his presentation, and then we can introduce the panel. So thank you for coming, and I'll turn the stage to you. Thank you.
Thank you. That was an excellent intro. I appreciate that. And thank you for having a very nicely ventilated room. We at WHO love it. So I'll let WHO in Geneva know about that. So I'll begin by just telling you the core tenets of the MPOX and COVID-19 communication campaign were rooted in the idea of communities leading communities. So this principle was cemented by our strategy during the 23rd International AIDS Conference in Montreal. The conference provided evidence as to why communities leading communities should be the best approach moving forward. And this is the conference's summary. Basically, they said communities generate high quality, unique evidence. Communities are co-creators, co-authors, and collaborators in research and community members. Community programming and advocacy is grounded in evidence and sharing. Community-led monitoring fills gaps and drives accountability. Community engaged as long-term partners in clinical research provide accurate insights on the experiences and receptiveness of cures and vaccines. So as a strategic communications consultant, this was music to my ears because all of this is exactly what we need in a strategic communications campaign. Basically, it has everything from principles, purposes, tactics, objectives. It has subject matter experts. It has a call to action. So because this provided us with everything we needed, we took this and ran with it. So the first thing we did was start involving LGBTQ communities and groups on our messaging. So WHO's approach was to highlight the significance of community engagement in public health campaigns. One of the first things we did was sit down with LGBTQ communities and actually ask them a lot of questions, because these were the groups who were at most risk during the MPOX outbreak. We noticed that the LGBTQ community was actually very well prepared, more so than any other community at that time. And they really wanted to tackle the MPOX outbreak and end it quickly. But what they did not want was people in white coats and researchers coming down and telling them what to do. They didn't want people in ivory towers in Geneva or Brussels making TikToks or videos and telling them exactly what to do. They already had an idea of how to create their own communication strategy. So out of this was born that what we wanted to do was create a communication strategy where we would put the LGBTQ communities on the forefront. So we started having regular consultations with community leaders at the LGBTQ advocacy groups at every level, from community, local, national, and federal, and allowing distinct voices to actually impact our campaign messaging. These leaders shared with us that there was a lack of information about MPOX at every level and the lack of guidance from healthcare professionals. A lot of them actually went to clinics and tried to get information about symptoms of MPOX, and they were met with disdain and stigma, so they had to leave and never come back. So the individuals did not know where to go to get just the basic resources and did not know what the symptoms looked like. They did not know what the treatments were and where they were available. And on top of that, they now had to deal with the stigma, which was becoming apparent, that was getting closely associated with MPOX and being gay or being part of the LGBTQ community. So these consultations also provided us with insights about language and how to create message content and how to use preferred communication channels. So we recognize the importance of accessible language in communication efforts, and we also decided to change our tactics and make it and turn it from more complex jargon to simple everyday language use. We had to use lingo like anal sex. We had to use lingo like group sex and sex toys. And we actually had to make sure that a lot of the language that was taboo and unorthodox was now part of our communication language. This ensured widespread understanding and engagement across diverse communities. And in today's digital landscape, data-driven decision-making has become paramount for organizations seeking to effectively engage audiences. At WHO, this approach was actually central to our content creation process, where we seamlessly integrated insights from various data points to inform our strategies and maximize impact. We use Google Analytics, we use brand lift studies and ad campaign insights, and our annual social media reports served as the bedrock of our data-driven approach. Over here, you can see some of the social listening that we graphed. A lot of times we noticed that whenever we used monkeypox, the right-wing group actually loved that phrase. And when we changed from monkeypox to mpox, a lot of liberals really enjoyed using that word because it got away from the racist undertones. So the metrics offered valuable insights into audience behavior, campaign performances, and trends within our digital ecosystem. Here's an example of how a member of the WHO Technical Advisory Group on monkeypox, or mpox, used data to inform and manage the mpox outbreak. So at the highest level of mpox outbreaks in New York City, the mpox cases were increasing rapidly within the suburbs of New York. Something needed to be done quickly to set up resources and vaccination sites for the LGBTQ communities to reach to. So collaborative research teams set up online anonymous surveys to find out where or in which neighborhood queer and trans people were residing and where they would go to have group sex. And this is all anonymous. So using this data and other aggregates, the research group was able to find out clusters of outbreaks and could then implement vaccination sites, put resources out there, and send out mobile clinics when people needed to get vaccines or treatments. So we also started using what the LGBT community uses for their own communication or meetup standards. One of them was called Grindr. So from meetup apps to pride festivals, WHO utilized a variety of platforms to disseminate vital information effectively. So WHO collaborated with the Grindr LGBT app, which is usually used for hookups, to disseminate information about Mpox and Mpox vaccine sites, resources, community outreach, and how to deal with the stigma that they're dealing with, leveraging its extensive database to raise awareness and promote safe sex practices. Quick note, on Grindr, when they say mask, it actually means something totally different. So language is important. Mask in Grindr means masculine, not putting a mask on your face. So sometimes we have to change the lingo for that too. So while data provided a crucial foundation, our content creative philosophy extended beyond statistical analysis. The audiovisual team and the social media team made sure that every case study was turned into an effective storytelling opportunity. We interviewed a lot of patients on Mpox. We interviewed a lot of patients on Mpox and who described how they got Mpox, what their symptoms looked like and felt like, and what their treatments looked like. It was the first time a UN health agency actually so proudly put out testimonials from HIV positive people and people who were suffering from Mpox. So we let them speak about their stigma and what they were enduring, and that was how we helped them. We let the community speak for themselves, and what WHO did was basically provide encouragement, the technical support, and the back-end support from social media platforms with tens of millions of influencers and followers. And we took to heart what the LGBTQ community told us at the very beginning, that they did not want to be preached to. So we let community leaders speak about prevention and treatment. We actually brought in community leaders into the studios to help and record their interviews. We spoke to queer individuals who shared how they were avoiding getting Mpox while they were living with HIV. We brought in LGBTQ community groups into our studios and recorded the messages on Mpox and handling stigma. We interviewed transgender activists who spoke about how to get resources and guidelines about Mpox. We created social media content anchored by LGBTQ advocacy groups on how to avoid Mpox while still living with their preferred lifestyle. And all of this was then collected and edited and packaged by our audiovisual team and then amplified on all of our social media channels. We try to create content which is 1 minute long, as we had discussed in the past, and make sure that nothing was too complicated and everybody could watch it. And then this was streamed to tens of millions of our followers and our audiences. So the campaign achieved extensive outreach, reaching 63 million users and garnering significant engagement across social media platforms. Collaborations with at-risk communities contributed to decreased Mpox cases in the European region, while WHO content was widely cited and the public health channels and media was using it. And event organizers like Pride Festival were also using our messages on their platform, demonstrating the campaign's success in raising awareness and mitigating the outbreak. This strategy was also utilized for the COVID-19 communication campaign, recognizing that impactful ideas often stem from deeper understanding of knowledge gaps. We use supplement data and quantitative analysis. So as you can see here, we are actually using Google data here and data from our websites and backend analytics to see what viewers, when they go on our website, are looking for and searching for. COVID-19 is still the third most searched topic, but viewers are also looking for cervical cancer, endometriosis, mental health. So yes, we are still creating content around COVID-19, but we also have to supplement it with new content because we want to create information and content about what people are looking for and more engaged in. So our goal is to minimize guesswork in content creation by strategically leveraging the data while remaining open to creative insights from our viewers and our audience. By monitoring social media channels for audience feedback and mentions of WHO, we gain valuable insight about audience sentiments, interests, and behavior. This data also fuels our content development process, guiding us to identify topics that resonate well with the audience's curiosity and desire for knowledge. So COVID-19, we used the global health data to structure the campaign based on the current COVID-19 situations in each region, leveraging transmission risk levels and vaccination rate per country. So here's how we did it. So for countries with high transmission and high vaccination rates, we had to create content that reminded people that COVID is still around, and we had to highlight the risk of long COVID. Where countries had high transmission and low vaccination rates, we had to create content to show the importance of vaccination to prevent severe disease and death. Where countries had low transmission and high vaccination rates, we had to remind people that COVID is still around and to take precaution. And for countries that had low transmission and low vaccination rates, we encourage people to get vaccinated before the next wave starts. So this helped us match the most critical messaging to the most relevant country and increasing the impact of each social media message. We also use something called A/B testing, which is usually used by organizations and marketing people. So what we wanted to do was test what creative messaging resonates the best. So we decided to design two sets of creative assets. One is more hard-hitting, which is factual, and the other one is more neutral and softer in tone, but is more explanatory. So here is one simple example. The more factual one is 7.9 billion people are still living through COVID-19. It's not over. And the simpler one is we are still living with COVID-19. We wanted to see which out of these assets gets the most reaction. And then we also supplemented them with another one with the 6 measures for anti-COVID. So these two sets were run simultaneously in order to provide statistical relevancy in learning on message framing for WHO's future campaign. A multi-cell meta brand lift study was also deployed to help understand the impact of WHO's campaign and messaging across the world. While brand lift studies are typically used by measures that impact the brand, WHO took an innovative approach and started using it to get shifts on people's perception and towards people's measurement of COVID-19 and engaging their vaccines. So regarding messaging type, the data suggests that given the right context, it's clear that both hard-hitting as well as softer messages both apply. This demonstrates that once again, the importance of tailored message and content towards audience needs. Based on these meta brand study results, we further adapted the assets into 8 additional languages and localized content through WHO's regional and country hubs and offices. So the COVID-19 campaign results reached 1.1 billion people, 1 in 8 on the planet. It gained 5.5 billion impressions around 84 countries. It engaged 24 million people across Meta's platform, which included Instagram, who didn't just stop scrolling to look, but also liked and shared the content. And the greatest achievement we found was the campaign that it motivated 32 million people to continue safeguarding themselves from the virus with the 6 anti-COVID measurements that we had created assets for. So once we had created content, we were amplifying it. We also had to realize that not everybody was coming to our channels to read what is there or to get all the information. We even tried going to communities, but sometimes you can't go to them and they can't come to you. So the next thing we could do is collaborating with technology companies. So WHO's collaboration to search engines like Google and social media giants like Facebook has further expanded access to reliable health information. We work closely with the platforms to ensure that those who are actively seeking COVID-19 related information are met with accurate content and up-to-date tailored information. based on their location and the language preference. For instance, the organization worked with Google to create a search result panel for COVID-19 vaccines, launched by both Google and WHO to provide comprehensive information on vaccine safety, effectiveness, efficacy, side effects, empowering them to make informed decisions about their health. Also, we collaborated with Wikipedia and other pro bono companies to facilitate expansion of public access to WHO infographics, all of our videos, and any of the guidelines. So, enriching Wikipedia's coverage of COVID-19 related topics in over 175 languages. This collaboration underscored WHO's commitment to democratizing access to health information, empowering individuals again to give them access to reliable resources and information about COVID-19. We also had to fight misinformation at the same time. So in the face of rampant misinformation and disinformation, we had to remain vigilant in the efforts to combat falsehoods and ensure that the dissemination of accurate information was happening timely. By working with social media platforms to enhance content policies and guidelines, WHO endeavors to prevent the spread of harmful or misleading COVID-19 misinformation and monkeypox or mpox misinformation. Furthermore, partnership with fact-checking organizations like the International Fact-Checking Network and NewsGuard technologies enable WHO to identify and counter misinformation narratives effectively, safeguarding public health and promoting informed decision-making. And finally, we created a network of healthcare influencers. So WHO joined forces with healthcare professionals who are active on social media and who like to build brand awareness and create an online network. We call this FIDES, named after the Greek goddess of trust. Currently, we have over 100 members, and our collective reach is over 50 million audience members. So basically, FIDES counteracts the spread of health-related misinformation on social media and supports the public to make informed, evidence-based decisions about their health. We basically create the guidelines and we hand it to anyone who wants to be a social media partner, and they can use the guidelines and knowledge translation and create content around it. In the back end, we put them in touch with social media platforms like X or Facebook or YouTube, who can give them best practices, and the rest is up to the algorithm. So in conclusion, WHO's collaborative efforts with technology partners, digital tools, social media platforms, and fact-checking organizations have been instrumental in reaching digital populations everywhere with the trusted information about mpox outbreak and COVID-19 pandemic. By leveraging the power of community voices and collaborating with community leaders and health influencers, we continue to fulfill our mission of fostering trust in health systems, promoting health, and keeping the world informed. Thank you.
I'm going to turn it over to Dr. Stephanie Tan to moderate a panel to discuss some of these issues further. Dr. Tan is a postdoc with the Institute for Pandemics, working closely with me on critical issues around health systems resilience, comparative health systems, and I am really delighted to have been able to work with Stephanie for several years, and she's really well placed to moderate this panel, given her expertise in many different global jurisdictions on health systems and policy. So over to you, Stephanie. It's your turn to come up and introduce the panel to discuss further. So thanks, Stephanie. Over to you.
But I will move from there. Hi, everyone. Thank you, Sarah, for the introduction. I would like to welcome our panel. So we have Dr. Shale, of course. I'd like to welcome Ishtiaq Ahmed, who is an assistant professor of computer science at the University of Toronto. We also have Nadia Kaidi, who is a professor at the Faculty of Information at the University of Toronto as well. And last, we have Emile Joseph, who is an associate professor in the School of Social Work at McMaster University. So thank you all for joining us today. So Shell's brought up some really interesting, engaging points about this idea of how we can appropriately approach issues of community engagement and collaborations with tech and combating misinformation and building trust with the public in order to build better health systems. So I'm going to welcome each of our panelists to begin with a brief response and some comments about how their discipline approaches these concepts. So Ishtiaq, can I hand it to you first?
Here, thank you. Thank you, Dr. Shail, for this really informative presentation. So a lot of things in this presentation that we saw kind of like resonated with the kind of work that personally I have been trying to be doing with local communities here in Ontario, Canada. And I will not go into the detail. I'll make my comment short, and I will highlight on a couple of things, and might be these are the things that might help us to foster the conversation next in this panel. One thing is that I really like this idea of reaching out to the communities in a respectful manner, respecting their privacy. And for doing that, using text message seemed to be a very good method. One thing that in our study, we found that when someone receives these text messages, oftentimes they also have questions. And text messages often, turns out to be a one-way communication where, a conversation could probably, give people further opportunities to learn, learn about the health concerns more. So that's something that we are now trying to work on. Well, being a computer scientist, definitely these days we are working a lot with building chat agents with our AI and other tools to see if those are helpful. So that brings me to the next point that I would like to hear more from the speaker and others, like how we are actually involving these communities. And misinformation is also something that we have been working on. One social media, what we saw during COVID-19 pandemic was that it was not only this wrong information about COVID-19 that was that got flooded over Twitter, Facebook, everywhere, but it also the hatred towards certain communities that was hard to handle. And the human moderators and Facebook, Twitter, they were not being able to do that. We were building AI tools to help them, and AI can only do so much. So this is a real problem. But the other problem at the same time that we are finding here is that the way often this fact-checking algorithms, and not only algorithms, even this fact-checking mechanisms by these human moderators often work is sanitized of, let's say, a faith and other things that are important to incorporate if you want to work with communities who are not necessarily based on, let's say, modern scientific way of knowing about diseases. And what happened there was that our algorithms and even the human moderators were not only deleting or taking action against the posts that have wrong information, but it was also being disrespectful to some of the communal teachings that are coming out of communal faith. And this was a very delicate a balance. It is not easy to do. So for the last few years, we have been working with community leaders how to come to a point where we want these scientific messages to reach to these communities, and we also want to do that in a way that's also respectful for them. So these are the things that that came to my mind, and I definitely want to hear more from the speakers and other panelists. But wonderful presentation. Once again, thank you.
Great, thank you for those comments. I think that this is giving us some really rich material for the discussion. Looking forward to hearing the panel interact with each other. So from there, can I pass it to Emil to share his comments and responses to both Shale and to Ishtiaq's comments?
Hello. Yeah, the presentation gave me a lot to think about. You know, when I hear words like community-led and data-driven, and you're thinking about communications and addressing misinformation, I couldn't help but thinking about really local ideas of community. And you helped me think about community kind of on a global scale. And especially when you're thinking about ways to address systemic or institutionalized forms of social disrespect for, you know, LGBTQ plus communities. In Hamilton, where I'm from, in particular, during the COVID-19 outbreak, some of the data was demonstrating that over 50% of people being infected around March of 2020 were racialized groups. And it was community leaders from organizations that do justice work for around hate, around inclusion, around accessibility. So the Disability Justice Network of Ontario, the Hamilton Anti-Racism Resource Center, the Hamilton Center for Civic Inclusion, these kinds of organizations who already do this work of addressing systemic issues in healthcare, in public health, and community health centers that also kind of do some of that work were really necessary in all of the piece parts of developing what just relationships might look like in addressing the problems. And, you know, they did things like started a specialized clinic to get vaccinations to the hardest to reach groups. They did so for free. They did so by organizing their own platforms to do bookings for the clinic. And, you know, they reached out to specific communities in different languages, meeting people's needs depending on how complexly we're thinking about and asking the question of who we leave out. And so when I think about, you know, data, one of the conversations that came about was like, whose data and for what purpose? You know, if you're going to collect data on a particular group and it can be wielded against us, how do you ensure that data and the communication and the actions are built in ways that are maintaining relationships with communities, acknowledging that most of those organizations are kind of small and they're underfunded. Like, I wish we had WHO resources. That would have made things different, you know? But how do you have those conversations in the local that connect to kind of the global? And I think we definitely can. You have to be careful about how you try to homogenize the local and the global. And, you know, when that specialized clinic started, there were a couple of kind of more white nationalist websites that kind of picked up this theme that vaccination was being targeted based on race. And that wasn't fun. You know, we received a lot of hate mail during that period of time. But it was also a moment where we could have used a lot of help to do the work of saying, communicating why this was important and why people were doing it well. And that's another piece of the work. You know, when you talk about community engagement, community led, there are community groups, community organizations, not-for-profits that know how to do the work relationally, respectfully, and do it well. And we can rely on them in ways that don't pretend they don't exist in the mix. But by validating them structurally in the relational work we do with, say, public health or globally. So we can look at the particular focused instances and support that kind of work as well. Yeah, I'll stop there.
Thank you. Is it working? Yes? Yeah. The acoustics of this beautiful room is not very good. So bear with us as we are nearing the end of the day, and so much richness of data, which was lovely. And I want to do a shout out to the previous speaker, Dr. Earn, for the modeling that he did, because I think that what would be really, really nice down the road would be to overlay some of that modeling with information data, social media data, the kind of data points that we have, messages, and see what the story unfolds. I also want to thank Rigong Shell for his presentation, because in some of the work that we are doing in the community, I work more at the micro and meso level, working with communities, doing a lot of ethnographic work, co-design workshop, in-depth interviews. WHO came up all the time. The infographics, the quality of the information, the readability of it really, really matters to people. So if it helps, you probably know that, but people often mentioned that information as having a credibility that really mattered a lot in the community. Building on what Ishtiaq and Emil kind of talked about, I want to mention this next layer, which is what happens at the individual level is really important. So I'm an information scholar. What we do is that we look at information flows, how information flows in different platforms through different formats, and that helps people make decisions about whether to vaccinate or not, and what to do, how to make decisions about theirs and their family health. So one of the study we did with our community partner in Ottawa, Refugee 613, during the COVID pandemic, was just to look at who do people in the community trust to go to for information. And what we found was it was the hyper-local nature of the relationship that really made a difference. So while it's great to have WHO, it's great to have CBC, and Antonio Fauci was often mentioned as a credible source, even in Canada. So we have the political figure, we have the social media influencers, but ultimately, really, people in your community matters. And I'm not just talking about physical communities, I'm talking about your digital messaging platforms. Who is on your WhatsApp, your Telegram, your Signal private platforms? And the flow and the very rich interaction, exchanges that people have are as important in terms of decision-making about health as any of the things we've talked about today, the projections and the modeling. So what we aim to do is really to map those information flows. And what we found, among other things, is they are local and transnational, both. So it's not one data point, it's always bilateral, multilateral. The second big important thing is the kind of unrecognized and unpaid labor that is involved in sharing, filtering, synthesizing, verifying information before passing it on. Who does this job, do you think? It is not just the institutions, not just the public health, not just settlement workers. It's also people in the community. So we call them digital champions. We had a co-design workshop, and Sabine was in that workshop. And the community told us we don't like digital champion, we are like digital connectors. So we tried to identify who these digital connectors were in the various communities. So we have a typology of who these important people are and the kind of work they do. And just to cut it short, we're trying to try to connect the work that you all do in this room with the work that happen in very intimate spaces. Because the intimate spaces really matter when it comes to credibility of information, uptake, risk management, and so on. So, so for you, Mrigank, I have one question, which is really about this invisible labor, this unpaid labor that many of these people in the communities do. You work with them all the time. You mentioned some of them for your campaign. But I think that, first of all, sharing data, especially by vulnerable population, is not always something that is desirable. Sometimes for them, it's like monitoring or surveillance. So how do we kind of reconcile that tension between kind of working with community, collecting data that matters, while at the same time protecting vulnerable communities who may not feel comfortable sharing certain kinds of data or promulgating certain messages? And I leave it at that. Thank you.
All right. Well, thank you so much for all your comments from the panel. I think that it's really interesting to think about these issues of community engagement and how do we get through and both reach out to equity deserving groups. And I think that's been a comment and a thread that's run through the day since our keynote, who spoke about how it's quite easy to get people who are really engaged and have a lot of trust in the health system to come and get vaccinations and be engaged. But what do you do for that more shallow part where it's harder to reach and you're using, is there some middle ground between bottom-up initiatives and these large-scale messaging from, say, multilateral organizations? How are some of the ways that technology is able to bridge can anyone comment as to if there are other ways that they're able to bridge those two gaps to try and pull in? Because I think we keep coming back to this idea that the number of people who are really engaged and really eager to take on this messaging is quite a shallow subset of the population. So how do you build trust and combat misinformation at a broader scale?
Is this on? Okay, perfect. I'll start by telling you guys that there's a new report that just got published. It's the Edelman Barometer. It basically is a think tank, a global think tank that does surveys around the world on trust and health. And it just asks people globally who they trust in. And consistently throughout the years, the healthcare community has been the most trusted ever, but recently has been declining in every single country. So that is concerning. But luckily, when asked which sort of job or which people you trust the most, every country rates doctors and nurses and healthcare professionals at the top. And the people who are at the bottom, the people who they don't trust, you think they're lawyers, but no, it's actually journalists. They have the least amount of trust. And before that, right before journalists, it's content creators on social media. But interestingly enough, if you ask them if the content creator is a doctor, what happens? That rating goes up 20 points, like really high. So I think this is an opportunity that we should be using to make sure that experts like yourselves are actually on social media and start creating content and start talking to people, because there is a void out there on social media that people, most of the younger generation is going on social media to get most of their information, because no one is reading 20-page academic articles anymore. We are, but a lot of the lay people are not. So, and news is also being cut down in 1-minute segments. And there are people out there who are calling themselves experts because they have a blue check mark, but they are not. So I think it's time for people who are in public health sector to actually take the baton and start answering some questions on social media and become the experts. I think that's how we will stop misinformation. That's how we'll reach out to people in communities and actually create some equitable healthcare. So I'll stop there.
All right. Yeah. No, I guess, like what Dr. Shale says made a lot of sense. What I hear from this discussion is that, and this is something I also believe, that the communities already have an information management system. They have a mechanism how, if a disaster happens, how they handles that. There are people, like who help these communities. So any technological interventions first need to understand how the community works, and then how the information actually flows in this community. And based on that, historically, we have been designing information systems. So a lot of discussions, and I understand like where there's like this tension actually comes from. It sounds like a bit more top down, that WHO now with this whole like a big tech like a power is not respecting this ongoing mechanism in these communities, and instead they are kind of like trying to pull up this like an age-old problem and imposing their solutions on them. We understand the strength of this internet and how things could go viral, but on the other hand, even this survey that you mentioned, I would like to know like who are the people who actually participated in the survey? It sounds like that the people who are already active on internet, on social media, and all these things, because they are being able to answer this question. Now, if you put that number in the global perspective, I don't know how much percentage that would make. So when we say like a community, and as like we and this table, even we are saying this like the marginalized communities who have been historically deprived of many resources, are those the people who are speaking of this? So this is also a question of like who we are like talking about. So okay, I'd stop it here.
At this point, we'd like to open up questions to the room. We've got our first one back there, and
Yes.
we've got 1 and 2 over here as well. Thank you.
So first of all, Dr. Shale, thank you for a great presentation. And I think it's so important that the WHO be here today. And so thank you for that. I have an awkward question that follows that, which is we've heard a lot, I think, of really, really passionate commentary about hyperlocal, about messaging for communities within communities. And the WHO has a problem where it's trying to actually do that hyperlocal thing, 8 billion people at a time. And you mentioned the A/B testing, which is a very effective tool when it's used for segmented populations, small segmented populations. I'm wondering how we can reconcile this with the WHO's mission to boil the ocean with every message, trying to reach everybody. And yet the reality that public health really is best and communication really is best when it's hyperlocal. I'm wondering whether the solution might be, for example, that the WHO invests not in crafting messages, but in crafting toolkits to allow public health units to craft messages in order to be able to do that. I'm just wondering, has that conversation happened at the WHO? Is there room for that conversation?
Thank you for that question. So yes, that conversation actually happened and is actually taking place right now. In the past, what has happened is HQ in Geneva decides the communication strategies, and then it trickles down. But we've realized that it's not working. And what we are now doing is giving countries and communities the power to make their own communication strategies, and we then supplement with our experts. So it's not trickle down anymore. It's a more symbiotic relationship where everyone is learning from everybody, and we are sharing what's working. So, for example, we've been doing Lassa fever vaccinations in a lot of countries in Africa. And we basically just go into communities and look at community leaders and ask them what's working for them. They've told us these sort of strategies are working. We need to make posters in certain languages. We need to sit down with community leaders under a tree in a village, and that's what's working for them. So we take that, we templatize it, and we share with other countries. Now, sometimes it doesn't work, sometimes it does, but basically it's a symbiotic relationship, and now everyone is working together. It's no longer top-down anymore. It's countries helping countries and communities helping communities. So I hope that answers your question.
Are we ready for infoepidemiology? This is infoepidemiology. You know about
I'm sorry, can you repeat the question?
we are ready for infoepidemiology. This is
Infodemic?
infoepidemiology.
Are you talking about the infodemic? I'm sorry.
Infoepidemiology. You know about
Oh,
infoepidemiology?
info epidemiology? I do know of the infodemic. I think that's what you're referring to, maybe? Okay, so at the present time, what we are doing is basically managing the misinformation and disinformation. Dr. Tedros, our Director General, has made it one of the key pillars to make sure that we are fighting the fake news that's happening within each country and around the world. And also recently, the US intelligence report came out basically saying that misinformation and disinformation is going to be one of the major problems around the world, and we need to fight that. So yes, to answer your question quickly, there are strategies in place for infodemic and misinformation and disinformation. There are actually strategies in place. We are working with infodemic sites. We are working with networks for fact checkers, as I mentioned. And once I get more information, I'm sure we'll put it up on our websites and people can actually share that. We actually have a guideline on how to fight misinformation and disinformation. It's a full-on strategy that we published. It's actually fully available to everybody to download. If you would like, I can share that with you later.
I was just thinking in relation to the kind of question around, equity seeking, equity deserving groups, marginalized groups, and the question about the hyperlocal. And in Hamilton there was a lot of conversation around vaccine hesitancy at the time. That was the language being used. And there was a vaccine readiness network that emerged with local agencies that serve hard to reach groups, those agencies that I mentioned earlier, but all the community health centers, Refuge, Newcomer Health, Centre de Santé Communautaire, Droit de Desne, the Indigenous Health Center, these groups of public health entities, community health centers kind of came together to think through their own ways of contributing by the knowledge of how they survive and how they work with those that have been traditionally left out. So when they brought that analysis to the table, the kind of counter to being described as hesitant was, hey, wait a minute. This health system hasn't cared for us and hasn't reached out to us in any kind of way that we can trust. So please don't talk about us as hesitant. Rather, I think if we want to build trust, then we could start from a place that acknowledges the kind of systemic, historical, political, social inequities that exist. And if we begin from there, that idea of like we're all complicit with a system that's unfair, then we can kind of get somewhere else. And so, part of the kind of information intervention has to also do some of the work of validating the kinds of ways that people have been left out and what we need to do to kind of bridge that gap. And a lot of that has to do with how we distribute resources to that effect. Like we could do the thing of, taking what worked in this particular circumstance and rallying behind the ways that these communities and community agencies and organizations came together to solve a problem. An example being, high-rise buildings in congregate settings had high incidences of COVID-19, and there were particular community members that needed a particular kind of communication. So, Somali youth working with the Disability Justice Network of Ontario went to talk to elders in the building personally, door to door, to kind of have those conversations around, hey, these workers are coming in and offering vaccination. This is what this means. And That was the kind of calm strategy necessary in that moment. But people knew what to do. We just needed to back them in the doing of it. And I think those kinds of ways that we can be respectful relationally in how we think about community locally and globally by supporting the local via the global strategy would be kind of important things to take forward, I think.
Can I just add something quick? You know, when it comes to misinformation, which is a huge war and epidemic ahead, I think that nobody will get it quite right how to fix misinformation per se. But what we do know is it's almost like a scale problem. So WHO and other kind of public health authorities will be able to provide information, but it's how it cascades down different levels that really matters. And sometimes you will provide somebody a factual piece of information, but they will not take it up, not quite yet, until it has circulated in different ways within the community. And to your point, Emil, really kind of having it being confronted to past mistreatment of the community or reluctance to trust a particular sector before that information kind of becomes more through redundancy and duplication and really being passed on through trusted people in the community. Only then that misinformation might have a chance to kind of, go away and better information will be taken up. The point is misinformation is not just about providing factual information. It's about understanding how information flows in the community, who it's taken up, who circulates it, and really having examples of the group you mentioned in Hamilton, faith-based community, other people who are trusted in WhatsApp, digital private messaging group, who translate it not only in another language, but through a different way of kind of talking about the issue. And only then we'll have a chance at fighting misinformation. But it's a bigger problem than just the information. It's really about trust in the healthcare system. It's about these reciprocal relationships with communities. So, yeah.
Okay, so I guess I wear many hats, but it kind of comes down to the same topic. So I run a family foundation. We focus on science literacy. So we put a lot of funds into science literacy and building science communication. I also run a science communication platform. I'm doing a PhD looking at the impact of social media-based science communicators. And during COVID, we formed a South Asian association where we did a lot of hyperlocal work with respect to translating materials, getting information out there to the community. The one obstacle I come across every single time has to do with funding, right? A lot of this work is unpaid. And there really aren't very many funding opportunities, especially for some of that hyperlocal work that a lot of you have alluded to. And when I speak to people, when I speak to healthcare providers and I say, why aren't you doing this work, right? It's because there's no way for them to get recognition. It's very difficult to get even academic recognition for a lot of this work. It's completely unpaid. And then the third aspect of this is that how do you measure impact? Because when you do this work on social media, there is no easy way to measure directly what impact you're having on changing behavior. So this ends up being this vicious circle where it's like that Spider-Man thing where everyone's just pointing fingers at each other. We need funding, we need recognition, and we need to measure impact, but we can't do one without the other. So I guess my question to all of you is, how do you fix this?
And go.
Go.
Sure. Yeah, join the line, I guess, everyone at WHO also feels the same way, about funding, about, there was a time when we were almost losing all of our funding because a certain president said he's going to pull out. So But I mean, I wouldn't be able to answer funding questions per se, but all I can say is there are, grants are available everywhere. And we all try to apply for them. But if you get them, good luck. And if you don't, I'm sure you can reach out to WHO technical advisory groups. We also have those. We can always help you find research and other grants. And on data and how to measure data, I'll say this, that in social media, we only measure data and impressions, and we try our best to, we don't correlate impressions to actual change in perception and behavior, but it is some sort of a gauge to see if something is working, if people are looking at something, if people are not looking at something. And then we have social listening, which we supplement with the data, which says, if people are commenting, if people are using the @ and responding and sharing, they are agreeing with something. If they're liking, they are actually liking the comments and the content that we are making. And there's a lot of hate also out there. So we can see, if somebody's writing a post, well, obviously they don't like it. So we have a team, we have a DDI department, the Department of Data Analytics and Insights at WHO, which is a new department that has been created because we realize that data is important. So we work hand in hand with that department to collect surveys as much as possible. We go around, we have vital statistics surveys in countries. We ask people how they're feeling about certain things, if they're getting enough vaccinations, if they're getting enough medicine, if they want additional guidelines on things. We actually ask people, and then we use that data, and then we change our strategy based on that. So social media, so to wrap it up, it's a gauge. We can't really tell you if it's working or not, but if it's trending, we think it's working. If it's not trending, we don't think it's working. That's simple as that. So I'll stop there.
All right. Should I go next? Okay. All right. Yep. Sure. All right. Yeah. So, well, I sit in computer science department. So let's say like a funding comes there mostly for all wrong reasons. But so I find it, and this is something that I'm often frustrated by, is that the amount of work that's needed to understand people, understand how community works, understand how people perceive a particular piece of information is a laborious work. It takes like years to understand the culture, the economy, the politics within the community, outside the community, all of these things. And only after that, you can think about designing something with the community that may help them. So oftentimes the funding only focuses on this last piece because that's where they see a lot of, revenue coming from. And that oftentimes we need to, do a lot of justification work for, to justify why we are doing all this groundwork to put a technology in place. So it's a challenge, and I'm not gonna deny that. The point that the closing remark that I would like to make is that there are like two things that I want to mention here. What I see and what I find particularly problematic here is that engaging with the community often means seeing community as an extractable resource. So you go to a community, you collect data from them. It's a very colonial way of looking at communities. And oftentimes we feel like, participation from the community is more democratic, but we also need to understand that sometimes this participation comes at the expense of sacrificing privacy, which is problematic. We have to think about how we can engage with the community in a respectful way so that we are not extracting their sensitive information, their labor, and we are not, exploiting this information in a way that we control their life and we put our governance upon them. So, yeah, so that was my concluding remark. Thank you.
I know we're coming down to the last minutes. I know everyone's really eager for an exit. I just want to ask Emil and Nadia if they have any closing comments, and then I will wrap up as the end of the.
Yeah, I think, the matter that you raised around trust. Trust is such a important thing to focus on. You can get caught up in thinking about the idea of information, either mining it, collecting it, distributing it, and thinking about impacts. But inside of a bigger umbrella of trust, where mistrust has been forged, consolidated and advanced and experienced in health system services, policy, practice, and law. And how do you address those things? Are they just about what one can learn? Or do we also appreciate that communities that have been left out, have been surviving, have a lot to offer? And there's people that know what they're doing and they're under-resourced. And that's a part of the puzzle as well. This kind of idea that we are misinformed about what capacities and resiliencies exist in communities to be agents of their own liberation, of their own change, of their own health. And it's got to be, I think, understood as a bigger matter of trust, a trust that we can build with one another, rather than seeing some or others as uninformed or misinformed or disinformed, which are global health concerns. Definitely, I agree. How we address it, though, I think could be under a kind of more welcoming umbrella, say trust, yeah.
And for me, I'm going to be very brief. Stephanie, you'll be happy, but just to thank the Institute for Pandemics and the Dalalana School to bring all of us together, because I really think the only way to move forward this dial is really by bringing different disciplinary perspective, different practices, different professions, and really try to think together. It's really the only way to combat misinformation and to support the WHO and others. So thank you very much.